Welcome to the session. Today we are going to deal with pelvic organ prolapse. So before we go into the details of the condition, let us see a little about the anatomy. So the first one which we are going to see is the elements comprising the pelvis. So what are the things which are there in the pelvis? Starting with the bones. And what are the bones which are there in the pelvis? They are ilium, ischium, and the pubic fusion. Secondly, we have ligaments. Ligaments will deal when we are talking about the condition. Next one, we have the muscles. In the muscles, the first one which we are going to tell about is the obturator internus muscle. Obturator internus muscle. Second one is the arcus tendinous levator ani. I repeat, arcus tendinous levator ani. Or you can call it to be a white line. Next one is the levator ani muscle proper. Levator ani muscle. And lastly, we have urethral as well as anosphincter muscles. So once again, we'll see the elements that are comprising pelvis are first one the bones, which includes ilium, ischium, and the pubic fusion. Then we have the ligaments. Then we have muscles. In muscles, we have obturator internus muscles. We have arcus tendinous levator ani, otherwise called as the white line. We have levator ani muscle, and also we have the urethral and anal sphincter muscles. Okay, then one more thing which we are going to talk about is very important one, and that is nothing but the endopelvic fascia. Endopelvic fascia, important one. Okay, now a short note of endopelvic fascia. They are the meshwork of collagen, elastin, and smooth muscle. I repeat, collagen, elastin, and smooth muscles. It's a meshwork of all this. And this extends from the level of uterine artery to the fusion of vagina and levator ani. And endopelvic fascia is attached to the uterus is parametrium. That is the cardinal uterosacral ligament complex. And when it is attached to the vagina in paracolpium, it's known as the pubocervical and rectovaginal fascia. I repeat, when endopelvic fascia, which is attached to the uterus, is parametrium, that is cardinal uterosacral ligament complex. Attached to vagina is paracolpium, that is pubocervical and rectovaginal fascia. Okay, now before we go into a little more details, so talk about the normal vaginal support. Okay, what are the supports of vagina? I'll, I'll tell it. Please be careful. One is the bladder, upper two-thirds of the vagina, and rectum lie in the horizontal axis that we all know. And urethra, that is one more. That is distal one-third of the vagina, and anal canal are vertical in orientation. Then we have a pelvic floor, which is horizontal and like a hammock. That is a levator plate. And lastly, we have a levator ani muscles and perineal body that support the vertical orientation of the vagina. Okay. And coming to the axis of pelvic support. Now there are basically three support axes. One is the upper vertical axis. That is, I've already mentioned, that is cardinal uterosacral ligament complex. Then we have a horizontal axis that leads to lateral and paravaginal supports. And lastly, we have a lower vertical axis that supports the lower third of the vagina, urethra, and the anal canal. Okay, so this was a little about the anatomy. Now, one more thing which is very important is the D. Lanfear's level of support. D. Lanfear's level of support, a very important one. Now, Here we have three kind of supports, three level of supports we can say. Okay. Now let us see the first one, that is the upper part of the vagina and apex of the cervix. Otherwise, we call it to be the apical suspension. Okay. Now, let us see what happens here. In this, the ligaments which are attached to this particular parts are cardinal ligament and the uterosacral ligament. Cardinal ligament and the uterosacral ligament. Okay. Now, if at all there is a um, tear or wear or any laxity in these kind of ligaments, the defects which are going to happen or the damage results in the prolapse of, there is a vault prolapse, that is a prolapse of the vaginal stump after hysterectomy. Then we have a apical prolapse, otherwise we term it to be the uterovaginal prolapse. Then we have an elongation of the cervix and the enterocele. So basically, upper part of the vagina and apex of the cervix, wherein the ligaments that are attached are the cardinal ligaments, or the ligaments that give support to that particular part are the cardinal ligament and the uterosacral ligament. And if at all there is a damage, then we have the defects, namely vault prolapse, apical prolapse, elongation of cervix, and enterocele. Okay, so coming to the second level, the level 2 support, that is the mid-vaginal or lateral attachment, we can say, the mid-vagina. Okay, the relations are to the bladder and the rectum. Bladder and the rectum. Now, when we talk about bladder and rectum, it is very clear that what are the damages that are going to happen. With respect to this, one more thing which you need to know is the ligament that gives supports to that, and that is the arcus tendon fascia. Arcus tendon fascia, and also you can say that the levator ani muscles also. Levator ani muscles. Plus, now what is going to happen? The damage that is going to happen is the cystocele and the rectocele. I repeat, the damage in the arcus tendon fascia, which is present in the mid vagina, the damages that are cystocele and rectocele. Coming to the last one, that is the distal perineal fusion. In that, the parts which are included are the lower one third of the vagina, related to the urethra and the perineum. Now here, the ligaments or the muscles which are, supporting to that is the perineal body and the muscles. And what is the damage? The damage results in the deficient perineal body or urethrocoele, as well as a lax perineum. A deficient perineal body or a urethrocoele and a lax perineum. So basically, this is uh, the D. Lansley's level of support. Now, with this particular, table, you can understand which part is involved or what are the ligaments which are involved, and if the damage happens, what are the defects that are going to happen. So this was very important one. It can be asked as a multiple choice questions, or even as in a UG, it is definitely asked once or twice, even in your viva or anything. Okay, so this was about the supports we have spoken. Then we spoke about the deal and flea support, level of support, a little of the anatomy. Now let's go into the topic proper. Now coming to the etiology of pelvic prolapse. Etiology of pelvic organ prolapse. Okay, now talking about the etiological factor, we have divided into anatomical, we have divided into the clinical factors. Let's see first the anatomical factor. The first one is the gravitational stress due to human bipedal posture. Second one is the anterior inclination of pelvis, directing the force more anteriorly. Okay. Next one, stress for parturition or internal rotation. During the time of internal rotation, there's a lot of the stress which is taking place to the muscles, causing maximum damage to the puborectal fibers of levator ani. Okay. Next one, the pelvic floor weakness due to urogenital hiatus and the direction of obstetric axis to the hiatus. This is one more. So next one is the inherent weakness of the supporting structures. That is basically the genetic cause. So once again, we'll deal anatomical factors, the gravitational stress due to human bipedal posture, and then next one, anterior inclination of the pelvis, directing the force more anteriorly, then stress of the parturition, and that point of time, there'll be damage to the puborectal fibers of the levator ani. Next one is the pelvic floor weakness due to urogenital hiatus and the direction of obstetric axis through the hiatus. Next one is the inherent weakness of the supporting structures, which is basically genetic in nature. Okay, so these were a little of the anatomical factors. Now, with this, one more thing I want to say is when there is a overstretching and overstretching of the endopelvic facial sheath, there can be a prolapse. Okay, now coming to the overstretching of perineum. So basically, whatever we are talking about in this anatomical factors is due to all this. Okay, the injury which is caused. Injury can be caused by the premature bearing down efforts prior to the full dilatation of the cervix. Can be. Okay, now coming to overstretching of perineum, overstretching and breaks in the endopelvic facial sheath, then loss of levator function, neuromuscular damage of levator ani or during childbirth. All this can be the an acquired factors leading to the pelvic organ prolapse. Now coming to the one clinical factors. Now in clinical we have a predisposing factor and an aggravating factor. I repeat, predisposing factors and aggravating factors. Now in the predisposing we have divided into the acquired and congenital one. Now, in the acquired and the congenital one, acquired one, the vaginal delivery with the consequent injury to the supporting structures is the most important acquired predisposing factor. I repeat, vaginal delivery with consequent injury to the supporting structures is the single most important acquired predisposing factor. Okay. Now, prolapse is unusual in cases delivered by cesarean section, actually. Okay, because in that we don't have to push the baby out, or we don't have to have a lot of we don't have to give a lot of force, or stress is not taking place in the muscles and the ligaments. So in that point of time, there is no question of a pelvic organ prolapse or uterine prolapse or a vaginal prolapse. There is no question of prolapse in case of cesarean section. Now, whatever these are, we are going to talk about only about the trauma of the vaginal delivery. Now, here we have mentioned a little points. So trauma of vaginal delivery causing injury, that is tear or break to the ligaments, endopelvic fascia, levator muscles, perineal body, nerve, that is a pudendal nerve, and then muscles, damage due to repeated childbirth. So these are the a few acquired predisposing factors that can lead to a pelvic organ prolapse. So basically, due to the trauma during the time of vaginal delivery, that will cause the injury towards the ligament, endopelvic fascia, then levator muscle, perineal body, nerve, that is the pudendal nerve, and the muscle. Next one, let's talk about the congenital one. Congenital one, you need to remember is the congenital weakness of the supporting structure is responsible for nulliparous prolapse or prolapse following an easy vaginal delivery. So congenital weakness should be the cause. So the sole cause of congenital, predisposing factor for having a pelvic organ prolapse is congenital weakness of the supporting structures. Okay. Now, in this inborn weakness of supporting structures, yeah, it is mentioned like this. Now, next one, the clinical factor, what we are going to deal with is the aggravating factors. Aggravating factors. Now, in case of aggravating factors, they are, the first one is the postmenopausal atrophy, poor collagen tissue repair with age, increased intra-abdominal pressure, as in chronic lung disease and constipation, then occupation, that is weightlifting, asthenia and undernutrition, obesity, increased weight of the uterus, as in fibroid or myohyperplasia. Okay, so these are the few aggravating factors. And remember that these factors possibly operate when the supports of the genital organs are already weak. Okay, if not everyone who does a weightlifting may have a pelvic organ prolapse, right? So what they mean is If at all already the genital organs are a little weak or the supports of genital organs are weak, then it super added to it, if the patient is having any of these conditions, then there can be a chance of pelvic organ prolapse. So that is what uh, they mean by the aggravating factors. So this is a little gist about the etiology of pelvic organ prolapse. Now, next one, coming to the types of genital prolapse, a little, bigger one. The first one, it's broadly classified. So the genital prolapse is broadly classified into vaginal prolapse, and uterine prolapse. Okay. Now remember that while the vaginal prolapse can occur independently without a uterine descent, the uterine prolapse is usually associated with variable degrees of vaginal descent. So it is not necessary for a lady to have, who is having vaginal prolapse to have uterine prolapse also. But when a lady is definitely having a uterine prolapse, we can see that she is also having a little degree of vaginal prolapse. That is what they mean. So vaginal prolapse is again divided into two. That is the anterior wall and the posterior wall. In the anterior wall, the first one we have the cystocele, and that to the upper two-third of the cystocele. Upper two-third of the cystocele. Now, the cystocele is basically, I'll tell, please note it down. The cystocele is formed by the laxity and the descent of the upper two-third of the vaginal wall. Now, as the bladder base is very closely related to this particular area, now what will happen? There is a herniation of the bladder to the lax anterior wall. So once again, when there is a laxity in the anterior wall of the vagina, now what will happen? The urinary bladder is situated just next to it. So there will be a herniation of the bladder to the lax anterior wall. Now that is how we have a cystocele. Now coming to the next one is the urethral, and that to the lower one third. Now, when there is a laxity of the lower third of the anterior vaginal wall, now what will happen? The urethra herniates through it. Urethra herniates through it. When there is a laxity of the upper two third of the anterior wall, we have cystocele. When there is a laxity in the lower one third of the anterior wall of the vagina, we have urethral. Okay, now this may appear independently or along with that of the cystocele. Now, when it appears along with that of the cystocele, we have the third combined one, that is a cystourethrocoele. So in here, there will be a laxity of the entire anterior wall of the vagina. Okay. So once again, there is a broad classification of genital prolapse. One is a vaginal prolapse, and the other one is a uterine prolapse. In the vaginal prolapse, we are going to deal with the first one is the anterior wall. Here they say that when there is a laxity of the upper two-third of the anterior wall, we have cystocele. When there is a lower one-third or laxity of the lower one-third of the anterior wall, we have the urethral. Here, the herniation of the bladder takes place, that is cystocele, and here the herniation of the urethra takes place, that is the urethral. Now, when the entire anterior wall is having a laxity, we have a combined one, that is a cystourethral. Okay, I hope this is clear. Next one, let's talk about the posterior wall laxity. Okay, posterior wall. Here, we have the first one is a relaxed perineum. Now, tone perineal body produces a gapping introitus with with a bulge of the lower part of the posterior vaginal wall. Now, the sole reason is the tone perineal body. So, relaxed perineum due to the tone perineal body. Next one, we have a rectocele. I repeat, rectocele. Now, there is a laxity of the middle third of the posterior vaginal wall. I repeat, middle third of the posterior vaginal wall and the adjacent recto-vaginal septum. Now, when there is a laxity of these, there will be a herniation of the rectum through the lax area. So, in case of a relaxed perineum, here there will be a bulge of the lower third of the posterior wall. Lower third of the posterior wall. Now, in case of rectocele, the laxity is in the middle part of the posterior vaginal wall and also the adjacent recto-vaginal septum. Please listen very carefully. The laxity or what is the reason that can lead to rectocele is the laxity of the middle third of the posterior vaginal wall and the adjacent recto-vaginal septum. Okay, recto-vaginal septum. And as a result, what will happen? There is a herniation of the rectum to the lax area. Now, this is what happens in case of a rectocele. The last one is the vault prolapse. In case of a vault prolapse, a little more which we have to see is, in case of vault prolapse, we have two, enterocele and we have a secondary vault prolapse. One primary and one secondary. Now, we'll deal with the primary one, which is the enterocele basically. So, laxity of the upper third of the posterior vaginal wall. Upper third of the posterior vaginal wall. Here, middle is over. In relaxed perineum, lower third is over. Now, in the upper third of the posterior vaginal wall. When there is a laxity of the upper third of the posterior vaginal wall, there will be a herniation of the pouch of Douglas. Pouch of Douglas. Okay, now it may not only the pouch of Douglas, but also it may contain the omentum or even a little small loop of bowel. And that is why exactly what we call it to be a enterocele. That is why we call it to be enterocele. Okay, now, so that was about the upper third of the posterior vaginal wall laxity, which will lead to enterocele. That is herniation of the pouch of Douglas. Not only pouch of Douglas, even a little of omentum and even a loop of small bowel. Now, next one, coming to the secondary vault prolapse. Now, this may occur following either a vaginal hysterectomy or an abdominal hysterectomy. Okay, so this is basically an acquired one. Okay, after a vaginal hysterectomy or a abdominal hysterectomy, basically the muscles and the ligaments, the supports, they become, they become weak, and that is the reason what happens here. Okay, so inadequate primary repair, if at all it has been done, or during the initial operation. So if at all there is a primary repair or inadequate primary repair, at that point of time, there can be a secondary vault prolapse. So this was about the vaginal prolapse. The next one we are going to deal with is the uterine one. Okay, the uterine, we have a uterovaginal and we have a congenital one. Uterine prolapse, we have a uterovaginal prolapse as well as a congenital prolapse. Now, talking about the uterovaginal prolapse, that is a prolapse of the uterus, cervix, and upper vagina. I repeat, uterovaginal prolapse is the prolapse of the uterus, cervix, and upper vagina. And this is the most commonest one. This is the most commonest one. Okay. Now, the cystocele occurs first. There is a sequence. First one, cystocele occurs, first followed by traction effect on the cervix, causing the retroversion of the uterus. Then the intra-abdominal pressure has got piston-like action on the uterus, thereby pushing it into the vagina. That is what actually happens. Okay, so here, not only the uterus, even the cervix and the vagina, there is a prolapse. The next one is a congenital one. Now here, in the congenital one, usually there is no cystocele. In uterovaginal prolapse, cystocele will be there, but in congenital prolapse, cystocele will not be there. That is the difference. Okay, now in this, the uterus herniates down along with the inverted upper vagina. And this usually occurs in the nulliparous women. And that is why even the congenital uterine prolapse is otherwise termed to be a nulliparous prolapse. Okay, so this was a little details about the vaginal prolapse and the uterine prolapse. So basically, types of genital prolapse. Okay, now coming to the next one is the degree of uterine prolapse. Very important one. We have to keep note of this particular diagram which is given over here. Okay, the next one also we have the diagram so that we can learn. Okay, please see the diagram very carefully. The degrees of uterine prolapse. There are basically, 3 degrees of uterine prolapse. Now, 3 degrees. Here I have written that is different one. This is basically the quantitative scoring of the pelvic organ prolapse. Okay. Now, let's talk about the 3 degrees. The first one, the uterus descends down from the anatomical. You can see the picture over here. Okay, let's go to the first one and see the picture. The uterus descends down from its normal anatomical position. So this is a normal one. This is a normal one. Here you can see the uterus descends down from its normal anatomical position. That is the external os at the level of the ischial spine. But the external os remains inside that of the vagina. Inside that of the vagina. Stage 1. Okay. Now, in the second degree, the external os protrudes inside or outside the vaginal introitus, but the uterine body is still remaining inside the vagina. Next one. The uterine cervix and the body descends to the outside of the introitus. Okay. There's a mild one. Okay. So, once again, I'll tell you. In case of the first degree, the uterus descends down from its normal anatomical position. The second degree, what happens is the external os protrudes outside the vaginal introitus, but the uterine body still remains inside the vagina. In the third degree, the entire uterus, cervix, and the body descends to the outside of the introitus, which we call otherwise to be the precedentia. Now here, what is important for you is this particular table which is given. Okay. Now, first one you can see, stage 0, there is no descent of the pelvic organs. You can see there is no descent of the pelvic organs. In the second stage, see, you can see there is a -1 and a +1 written over here. That is basically the centimeter. Okay. Now, the first one is the leading edge of the prolapse remains 1 centimeter or more above the hymenal ring. There is a hymenal ring which remains 1 centimeter above. Okay, or above the hymenal ring. Next one. Leading edge of the prolapse, leading edge. I think this one is the leading edge. Leading edge of the prolapse extends from 1 centimeter above to 1 centimeter below the hymenal ring. Third one, from 1 centimeter beyond the ring, but without complete vaginal eversion. Vaginal eversion has not occurred completely over here. And lastly, essentially complete eversion of the vagina. Complete eversion of the vagina. So this is basically the pelvic organ prolapse. There's a quantitative scoring. Okay. This actually, the pelvic organ prolapse, the quantitative scoring, they have been recommended by the International Continence Society because it standardizes the terminology and is most objective and is specific and specific. And also it is a little anatomical. So that is what they say. So this was about the uterine prolapse as well as a little about the pelvic organ prolapse. Okay. Now, let's see a little of the morbid changes. So talking about the morbid changes, the first one which we are going to deal with is the vaginal mucosa. Vaginal mucosa. Now, remember that the vaginal mucosa will become stretched. Vaginal mucosa will become stretched, and if exposed to air, it becomes thick and it becomes dry with a surface keratinization. Now, this is what happens in case of vaginal mucosa. Remember, the vaginal mucosa becomes stretched, and if at all it is exposed to the air, it becomes thickened and it will become dry with surface keratinization. So, this is about the vaginal mucosa. Coming to the cervix. So, one more thing about the vaginal mucosa, I would like to say that they can be even a pigmentation. Okay, even a pigmentation can come up. So this was about the vaginal mucosa. Coming to the cervix. Cervix, we have two parts which we're going to deal with. One is the vaginal part, and the other one is the supravaginal part. Now, in case of a vaginal part. Now let's see in a different slide. So talking about the changes in the cervix. Talk about the vaginal part of the cervix. Here there is a chronic congestion. Due to the chronic congestion, they may lead to hyperplasia of the cervix. Hyperplasia and hypertrophy. Hyperplasia and the hypertrophy of the fibromusculoglandular components. And these lead to vaginal part becoming bulky and congested. Okay. Now, then addition to it, there can be infection, and if infection is there, it will lead to purulent or blood-stained discharge from ulceration. So that is basically that happens in the vaginal part. Next one, coming to the supravaginal part. I repeat, supravaginal part. Now, supravaginal part, basically, it will become elongated. It will become elongated due to strain imposed by the pull of the cardinal ligaments. Now, basically, cardinal ligaments, what they do? They try to keep the cervix in position. Okay, but what will happen due to the strain and all that? Basically, the prolapse is trying to occur, right? At that point of time, the supravaginal part will become elongated due to the strain which is imposed by these cardinal ligaments to keep the cervix in position. Whereas the weight of the uterus makes it fall through the vaginal axis. So here it will become elongated. This is what you need to remember. The supravaginal part will become elongated. So these are the changes that occur in that of the cervix. Vaginal part, hyperplasia and hypertrophy of the fibromusculoglandular components. Then, because of these, the vaginal part will become bulky and congested. Okay, and in addition to it, if infection is there, then definitely there is going to be a purulent discharge, or at times a blood-stained discharge from the ulcerated part. Next one is supravaginal part. In the supravaginal part, basically elongation will be taking place. That's what is of the cervix. So next one here is about the bladder. Now talking about that urinary bladder, urinary bladder, we have there is going to be a incomplete emptying of the bladder due to the sharp angulation of the urethra against the pubourethral ligament during straining. So what you need to remember, there is going to be a incomplete emptying. Incomplete emptying. Okay. So one more thing with regards to this is about the ureters. Now the ureters are carried downwards along with the elongated Meckenrod's ligament. Okay, so basically what will happen? There will be a mechanical obstruction that is going to take place. And that is from the hiatus of the pelvic floor. Okay, so because of this, there might be hydrouretic changes that may occur. Not that important, but these three are very important, which you need to remember. Okay, so next one is a few symptoms of uterine prolapse. The symptoms are usually variable, and even with the minor degree of prolapse, the symptoms, now here, the minor degree of, even if there is a minor degree, the symptoms may be pronounced, or paradoxically, there may be any appreciable symptom, even in a severe degree. Now, the following symptoms which you're going to deal with. The first one is feeling of something coming down per vaginum, especially while she is moving out. One symptom. There may be variable discomfort on walking when the mass comes out from the uteritis. One major and the most common symptom faced by the patients of uterine prolapse. Second one is a backache or dragging pain in the pelvis. Now remember these two, one and the two. These two symptoms are basically ameliorated when lying down. On lying down. Okay. Next one is the dyspareunia. Then we have urinary symptoms. Now, if at all there is a cystocele, there is going to be urinary symptoms. Now, what are the urinary symptoms? They can be difficulty in passing urine, or more the strenuous effort, the less effective is the evacuation. Next one, incomplete evacuation may lead to frequent desire to pass urine. Then urgency and the frequency of micturition may also be due to cystitis, painful micturition due to infection. Then there can be even stress continence, and that is usually associated with the urethral. Now, retention of urine may be a little rare one. So basically, these were the urinary symptoms. So remember, difficulty in passing urine, incomplete evacuation, urgency and frequency, painful micturition, stress incontinence, important ones. Next one is about the bowel symptoms. Now, in bowel symptom, remember that is in the presence of rectocele. Bowel symptom in presence of rectocele. Okay. Now, here there will be difficulty in passing stool. The patient has to push the posterior vaginal wall in position to complete the evacuation of the feces. Now, fecal incontinence also may be associated. So this was about the bowel one. Next one, excessive white or blood-stained discharge for vagina is due to associated vaginitis or even due to decubitus ulcer. So you may think why there is a decubitus ulcer. Because see, decubitus ulcer basically is a trophical ulcer, right? A trophic ulcer, always that is found at the dependent part, at the prolapsed mass lying outside the introitus. Okay, so basically what will happen, they can get keratinization, then followed by cracks, then infection, then sloughing, and followed by ulceration. So this is basically what happens. And when there is all this, there can be excessive white or bloodstained discharge, infection, basically. Okay, so these were the symptoms of uterine prolapse. Now let's come to the clinical examination of the pelvic organ prolapse. So here we're not only dealing with the uterine prolapse, but also the entire pelvic organ prolapse. Okay. Now let's do a composite examination. What and all we have to do? We have to do an inspection. We have to do a palpation. Okay. Now here, what and all we're going to examine? We're going to examine the vaginal, rectal, rectovaginal, or even under anesthesia, we have to even try to arrive at a correct diagnosis. So basically, a few general examination you are supposed to do, including BMI, signs of myopathy or neuropathy, then features of any chronic airway disease or any abdominal mass should be checked for. Basically, go back to your etiological factor and then check for. We need to rule out all the conditions which may lead to a uterine prolapse, or sorry, which may lead to a pelvic organ prolapse. Okay. So now pelvic organ prolapse is basically evaluated by a pelvic examination in both the dorsal and the standing position. Okay. Now, first one, let's see what will happen. There is a bulge. Remember, there is a bulge of varying degree of anterior wall, vaginal wall, which increases when the patient is asked to strain. In which condition there can be? It can be in the cystocele. So this picture is the cystocele. Okay. Here we had already mentioned that the herniation of the bladder will be taking place. Okay, so here what they say is, in case of a cystocele, there is a bulge of varying degree of anterior vaginal wall, which increases when the patient is asked to strain. Okay, now this may be seen on inspection. Okay, so what will happen in cystocele? When we ask a patient to strain, there will be varying degree of the bulge of the anterior vaginal wall. Okay, now coming to the rectocele as well as enterocele, we can say both. When these two conditions exist together, now there is a bulging of the posterior vaginal wall with transverse sulcus between the two. Okay, a transverse sulcus between the two. So basically, the mid-vaginal one being the rectocele with diffuse margin and reducible. So this is something which happens in the enterocele as well as the rectocele. When these two come together, there is a bulging of the posterior vaginal wall. You can see when we are going to, palpate in the posterior vaginal wall, we can feel a bulge in the posterior vaginal wall with a sulcus between that of the two. Okay, so this is basically the sulcus, the one in the blue, and there will be a bulge in the posterior vaginal wall. And in the cystocele, when we are trying to do a palpation again, this anterior vaginal wall, there will be a bulge. So basically, this is what we see in the systemic examination of the pelvic organ prolapse. Okay, now coming to the management of pelvic organ prolapse. So now before that, we can even check for, or we need to even know about the differential diagnosis. Differential diagnosis of the pelvic organ prolapse. Okay, let's talk about the cystocele first. So cystocele is often confused with a cyst in the anterior vaginal wall. Cyst in the anterior vaginal wall. Simple one. Even cyst, when there is a when there is a cyst, even we can feel on palpation, we can feel a mass kind of, right? Okay. So the cyst in the anterior vaginal wall is usually confused. Now, which is a cyst that has been in the anterior vaginal wall, which can get confused with the cystocele, and that is the Gartner's cyst. Gartner's cyst. Okay. So next one, we're going to deal with the uterine prolapse. The uterine prolapse, basically, there are three things with which we can say that we can get confused, or we can have a differential diagnosis of a uterine prolapse. The first one is congenital elongation of the cervix. Congenital elongation of the cervix. Second one is a chronic inversion. A chronic inversion. And lastly, a fibroid polyp. A fibroid polyp. So these are the differential diagnosis of cystocele as well as a uterine prolapse. The most two important things. Next one, coming to the management of the pelvic organ prolapse. So coming to the management of the pelvic organ prolapse, we have a preventive, we have conservative, as well as surgery. Now let's talk about the preventive, important ones. The following guidelines will be prescribed to prevent or minimize the genital prolapse. So first we will divide into two. That is the adequate antenatal and intranatal care. So to avoid injury to the supporting structures during the time of delivery or vaginal delivery, either a spontaneous or a instrumental. It is very important for us to avoid the injury to the supporting structures. You have to be very careful. The second one is adequate postnatal care, in which we have to encourage early ambulance. Ambulance means what? Doesn't mean the ambulance which is going to come. Ambulance means little moving here and about. You have to move here and there. Okay, a little motion. So next one, we have to encourage pelvic floor exercises by squeezing the pelvic floor muscle in the puparium. Okay. So this is what about the postnatal care and adequate and antenatal, internal and intranatal care. Next one, there are two general measures which we have to check out for. We have to avoid strenuous activities, chronic cough, constipation, and heavy weight lifting. And we have to avoid future pregnancy too soon and too many by contraceptive practices. Okay. Repeated pregnancy may lead to weakness of the or laxity of the uterine support and the uterine muscles. That may lead to the uterine prolapse. Okay, so basically there should be a gap between two pregnancies. Okay, now next one we go to a conservative. In case of conservative, there are a few indications of conservative management. There can be a asymptomatic women, mild degree prolapse, or a pelvic organ prolapse in early pregnancy. So basically we can do a pessary treatment. A pessary treatment. Now it should be emphasized that the pessary cannot cure the prolapse, but just it can relieve the symptoms. Okay. And how do they relieve the symptoms? They relieve the symptoms by stretching the hiatus urogenitalis, and thus they can prevent the vaginal and uterine descent. Okay. And also, we can tell the patient for a Kegel's exercise. Kegel's exercise. Now, what is the main your motto of a Kegel's exercise? They can basically strengthen the voluntary muscles of the pelvic diaphragm. Strengthen the voluntary muscles of the pelvic diaphragm. So, this was something which was very important for you people to know. That is the pelvic organ prolapse. So, I hope you might have understood. Thank you. Please go back and read one so that it remains in your mind. And any point of time, if someone is asking, you can answer any of these questions. Thank you.